And I'm going to be talking about the concept of inflammation and the conditions of the GI tract and renal system that include inflammation. Let me know if you can't hear me. I'll try to talk louder. That kind of thing. Questions? Go ahead and get started. So the concept of inflammation. What is inflammation? So inflammation is the normal and expected physiological response to cellular energy. So it's the normal and expected physiological response to cellular injury. This response is protective in that it provides an opportunity for the body to heal and repair the injury. So as a concept of inflammation, it is defined as an immunologic defense against tissue injury, infection, or allergy. So it's an immunologic defense against tissue injury. So the immune system jumps in to defend against this tissue injury that's occurring, or an infection, or an allergy. Inflammation jumps in. So an acute inflammation is the immediate response to tissue injury. And the acute inflammation is a short duration. So it only lasts like minutes to days. The characteristics of inflammation is you'll have redness, swelling, heat, warmth, pain, and loss of function. The characteristics of acute inflammation is you'll see redness, swelling, heat, pain, and loss of function. The three physiological changes that occur with inflammation are increased blood flow, so blood rushes to the site, increased vascular permeability, and increased migration of leukocytes from the blood to the tissue. So it's increased blood flow or hyperemia. That's Hyperemia. Hyperemia. Increased vascular permeability, and then also increased migration of leukocytes from the blood to the tissue. So what are the first white cells that we see come to fight off inflammation? Neutrophils. Think about neutrophils. The first one up to bat. After that, the macrophages. Now, chronic inflammation continues for weeks to years. So after an initial injury, the tissue is repeatedly being destroyed and repaired, thus impairing the healing process. An example of a chronic, anyone come up with a chronic inflammation medical diagnosis? Or arthritis, rheumatoid arthritis, that's a good one. So they're autoimmune diseases, and also they include like ulcerative colitis and Crohn's disease, which we're going to talk about. caused by obstruction by a stone. And so coli is gallbladder, cystitis is bladder. The bladder portion of it. If the patient has gallstones, it's cholelithiasis. And like I said, that is the most common problem or common cause of cholecystitis is gallstones. And the pain comes with the obstruction from these gallstones. So cholelithiasis is the formation of these stones. Women between 20 and 60 are twice as likely to develop gallstones as a man. So us women get hit harder with gallbladder disease. Related to, also known as our what?
Risk factors.
I'm sorry?
Risk factors.
Okay, or causes. What's causing gallbladder problems? Yes. So there are risk factors. There is a familial or genetic tendency. So there is a tendency that this happens in families. Another risk factor is sedentary lifestyle. Also obesity. Because obesity leads to impaired fat metabolism or increased cholesterol. So the gallbladder has to work pretty hard to get rid of that cholesterol. Also, increase in age. The older we get, the more likely this can happen. Diabetes mellitus is another risk factor. They usually have higher levels of fatty acids. And they find that this is more prominent in American Indians. Possibly this is due to the increased incidence of diabetes mellitus in American Indians and obesity. Also, a risk factor is having Crohn's disease. Gastric bypass surgery. And they've also found birth control pills or hormones to cause gallbladder disease. Some women experience gallbladder problems during pregnancy. Because if you think about all the GI tract slows down, so there's stasis in the gallbladder, so those stones can start accumulating or developing, I should say. What I first learned when I was a young nurse was the 4 F's. Does anybody know what the 4 F's that are risk factors for developing gallbladder disease?
Female.
Female. Puts you at risk. Anybody else?
Fat.
I'm sorry?
Fat.
Fat, yeah. Saying it bluntly, right?
Fair skin.
That's not one of them, but you're right. It does tend to be in fair-skinned people. Female, fat.
Familial. Yeah, family too.
40. 40. And fertile.
Fertile.
So those are the 4 F's, risk factors for gallbladder disease. Okay. So, as manifested by or what? described as episodic or vague in the upper abdomen, and it can sometimes radiate to the right shoulder. So episodic, comes and goes, can be kind of vague, and it's usually in the upper abdomen that can sometimes radiate to the right shoulder. We'll also see when we're assessing these patients, we'll assess them for rebound tenderness, and this is called Lundberg's sign. Lundberg's sign. Oops, what I did. Yeah. And that's rebound tenderness. So if you palpate the abdomen, they go, ooh. And that's called Lundberg's sign. Rebound tenderness. When you're getting the history of the patient, what is one of the triggers that can trigger pain? Maybe some of you have experienced gallbladder. Eating fried foods, big one. So pain can be triggered by, you'll find in the history, by a high fat or high volume meal. So if they're eating big meals or fatty meals, that gallbladder's, trying to digest all that, or help with the digestion with the bile. And so if there's a blockage, then it's trying to get that bile through and can't get it through, and that's when the pain happens. You'll also see nausea sometimes in these patients coming in, anorexia, dyspepsia. What's dyspepsia? Indigestion. Eruptation. What's that big word? Belching. Flatulence. I know you know what that is. Gas. And abdominal. So they'll have nausea, vomiting, anorexia, dyspepsia or indigestion, eructation, flatulence, and abdominal fullness. They may have a fever. They may complain of what's called biliary colic. Biliary colic is, or also known as cramping type pain. You'll see this when they talk about, I get really crampy after I eat. This occurs when the stone is lodged in the cystic or common bile duct. So biliary colic, or cramping type pain, occurs when the stone is lodged in the cystic or common bile duct. If the stone blocks the duct, edema, inflammation of the gallbladder occurs, and is sometimes associated with jaundice. So some of these patients will come in with jaundice. That bile is backing up into the bloodstream. So biliary colic or cramping type pain occurs when the stone is lodged in the cystic or common bile duct. And if the stone blocks the duct, edema and inflammation of the gallbladder occur. And maybe seeing jaundice, patient may be seeing jaundice. If our patient is jaundice, what do you think their stools may look like?
Sorry.
Yellow? No. Okay, so think about it. So the bilirubin is backing up the bloodstream. Typically, it's being distributed into the intestines to help with digestion. Clay-colored stools. So that's another indication that they have a blockage, or clay-colored stools. What do you think their urine will look like?
Dark.
Dark.
Amber.
Yeah. Yeah. almost bile color, kind of brownish, very dark. Kind of look like it has a little bit of bile in it. Okay, so the bile is not coming through, and bile helps to digest fat. So, what do you think the stools will be like?
Dry.
Fatty stools, you'll see. And that is called Steatorrhea. Maybe I'm pronouncing that wrong. Steatorrhea. Steatorrhea. So that means fatty stools. Because the fat is not being absorbed because of the decrease or lack of bile. Okay. Intervention. Hands. So I will. Okay, so what will we be looking at?
Bilirubin.
Bilirubin, exactly. Direct or conjugated bilirubin. And what do we expect it to be? Elevated. Right. If there's an obstruction by a stone, it's going to back up into the bloodstream. We'll look at a CBC and see if it indicates whether there is an infection. Also, you may see it elevated a little bit from what? Just maybe not an out-and-out infection, but what else can cause our white count to elevate? Inflammation. So maybe a little bit up, not really high, but just a little bit because of that. An amylase and lipase. What would cause our amylase and lipase, and what would they be? What would we be looking at here? Pancreas. Pancreas is right there in the same vicinity. So, we know what the pancreas does. It also helps with digestion. So if it's being affected, the amylase and lipase are going to be up. So we may have have you ever had a patient who came in with pancreatitis and come to find out that they had gallbladder problems, gallstones? Typically, pancreatitis, we think of what? Well, it could be cancer. Usually it's associated with alcohol, but we can't jump to that conclusion because sometimes it's because the gallbladder has gallstones. Okay, and then the liver, what do we expect the liver function test to show? Alkaline phosphate. What's that? Actually, they're going to be elevated too because the liver's right there and could be affected also because of the obstruction. So we're also going to be monitoring abdominal x-rays, and these may reveal stones, but only those stones that are calcium-based. Most stones are not radiopaque. In other words, most stones they can't see on abdominal x-rays. What they can use is a gallbladder ultrasound. And the gallbladder ultrasound is used to identify stones, gallbladder and ductal dilation in non-obese patients. Another test that can be performed is ERCP. Has anyone had a patient in the hospital? Yep, that's gone down for one of those. Typically, those are done when the cause of the cholecystitis or cholelithiasis is not known, or the patient has manifestations of biliary obstruction or jaundice. So those initials are endoscopic retrograde choleangiopancreatography. Oh, that's why we call it ERCP. So, it is ERCP, okay, endoscopic, retrograde, choleangio, this one you got to pronounce, pancreatography, ERCP. Has anyone gone down to see it, ERCP? Taylor, how'd they do that? Do they have to inject any dye or anything?
I don't think my patient.
Okay.
They had both of those at the MRCP.
Okay. 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 Anybody else seen one of those done? You don't see them done very often, but occasionally we will have a patient who's having that done. And then the other one is the MRCP. And that stands for magnetic resonance, sorry, the same big word. So it's an MRI, magnetic resonance. Pancreatography. This is less invasive and considered safer.
Safer?
Yeah. Do they go in like through the mouth and look around? Okay, great. There you go. Thank you, Candace. Okay. Okay. Interventions. So they're going to be in a lot of pain, so we're going to be giving them pain medications. The medications of choice are morphine or hydromorphone, ketorolac, I like Toradol better, antiemetics because of the nausea and vomiting. We're going to limit their dietary fat. Surgeries, and I'll go into more detail in just a second, which lithotripsy, more like a procedure, laparoscopic cholecystectomy. What does cholecystectomy mean? Removing the gallbladder, right? Then there's the traditional cholecystectomy and T-tubes that we'll talk about. We used to give, when I was in surge, we used to think that Demerol was the best pain medication to give because it didn't cause spasms of the sphincter of Oddi, which would cause bile to be blocked. But what they found with Demerol is it breaks down into a toxic metabolite and can cause seizures. So now we use morphine and hydromorphone. The reason Demerol is because morphine was thought to cause the spasms, but it was found that most of the most all of opioids cause sphincter spasms. So the Demerol, I thought that was really interesting. I had not heard that until I read that in your book. That the Demerol breaks down into a metabolite that cause seizures, especially in older people. Have any of you given Demerol lately? I can't remember the last time I saw Demerol given, so I don't think they're using it anymore for that very reason. Anyway. Toradol is a what?
NSAID.
NSAID. So why would we give them an NSAID? Inflammation. Which we give them something to decrease the inflammation and also decrease the what? Pain. Yeah. Everybody knows what antiemetics are, right? Bile salts can accumulate also because of the obstructive jaundice, and you may see your patients itching, or they'll have pruritus. A medication that can be used for that is called Chron. So it helps reduce the bile salts that cause itching. So if your patient is itching and jaundice, it's because of those bile salts that are circulating in the bloodstream. Now, a fairly new surgery/procedure is lithotripsy. Why do we typically use lithotripsy? Break up kidney stones, right? Or urinary tract stones. But they found that this also helps with gallstones. So sometimes this is used along with the drug that is given afterwards to dissolve the large gallstones. However, if the cholelithiasis is symptomatic, then they usually just do a lap chole. Lap choles are great because they have a low risk of complications. The patients are generally sent home in 24 hours. And post-op care is just as important, however, especially monitoring for bowel sound. They usually go home much quicker. Has anyone seen a traditional gallbladder surgery done? It's a big old incision. Yes. It goes all the way across this way. So these patients have a lot of pain. What else do you think is affected by that? Big old incision.
Bowel.
You know, it's just breathing. Every time they take a breath, they feel that, so they have a lot more pain, a lot longer recovery. And we'll talk more about the bile issue in a little bit. But we don't see those too often, and I was so glad because in the last 20 years, they've greatly declined. The only time you're going to see one of these typically is if the patient has severe biliary obstruction and they feel like they need to get in there and see what's going on. So I remember when lap choles came out, I was like, yes, I never have to have a gallbladder. I just can have these 3 little incisions instead of this huge thing, huge scar. So that's been a great improvement for gallbladder surgery. T-tubes, I can't remember when the last time I saw a T-tube either. T-tubes are used when stones are suspected to be lodged in the ducts. And it is placed in the common bile duct to assist with the passage of bile until the edema has decreased. So with the traditional cholecystectomy, they open the patient, they of course look through the bile ducts, and get the stones out, but that will cause some edema to occur in the bile duct. So they put this tube, and it's a T-tube because it goes straight through the tube, and then it comes out to the skin and drains the bile in there until that edema goes in. So the bile collects in a bag by gravity, Patients must be placed in Fowler's position to promote this drainage. And of course, like any output, drainage is recorded and should decrease over time. And usually these T-tubes stay in for a week or more until that edema goes down. So one more time, T-tubes are used when stones are suspected to be lodged in ducts, and it is placed in the common bile duct to assist with the passage of bile until the edema has decreased. Okay. I'm sure you guys need a break, right? Okay. How about stomach's in here also, dumping the food in. You also have the pancreas down here that's feeding the pancreatic enzymes into the duodenum to digest food. So that picture, if you know, if you want to review the anatomy and physiology, I know it's a good thing for me sometimes. That picture is on 1316 in chapter 62. I did not include that in your reading, but it is good because I think it puts it in better perspective to see it like this. So it's 1316 through 1320 in all your spare time, extra reading time. That would probably be a good thing to look at. Okay, all righty. I looked up also about the endoscopic, and that's exactly right. ERCP, it is through an endoscope. And they use a fiber optic endoscope, and it provides radiographic visualization of the biliary and pancreatic ducts. So they can see the pancreatic duct and the biliary duct. This is especially useful in patients with jaundice, as we talked about. If there's a partial or a total obstruction, you can tell where the obstruction is. So they can see stones, benign strictures, cysts, stenosis, malignant tumors. And what they do is they feed the scope down through the stomach and, let's see, passed into the duodenum, and note that the catheter being advanced into the biliary duct. So it goes in the stomach, through here, and looks through here. Checks everything out on the way. So that's what that is. And again, the magnetic MRCP is less invasive. It is less invasive, and they can get an image of the biliary tree, gallbladder, pancreas, and pancreatic duct. So those are good tests. Any questions before we move on to inflammatory bowel? So the two most common inflammatory bowel diseases are split equally between Crohn's disease and ulcerative colitis. 1.4 million people in the United States have one of these. We're going to start with ulcerative colitis. And ulcerative colitis is an inflammation of the mucosa in the colon and rectum. So it's in the lower part of the GI, the large bowel, large intestine. Cause is unknown, but peaks between 15 and 25 years, and then comes back around when people are 55 to 65. So it's a couple times.
Now, is that only if you've had it between the earlier years?
It didn't say, so I'm thinking no, you're just not clear until you get past 65 maybe. That's a good question. So ulcerative colitis creates widespread inflammation in the rectum and rectosigmoid colon, but actually can extend to the entire colon when the disease is extensive. Ulcerative colitis is associated with periods of remissions and exacerbations. What are remissions? Flares up. Breaks. Exacerbations? Yes. Yes. Many factors can cause exacerbations, including intestinal infections. The intestinal mucosa becomes hyperemic. Hyperemic means it has increased blood flow. It gets edematous and reddened. And in more severe cases, the lining can actually bleed and small erosions or ulcers occur. So the intestinal mucosa, now you want to keep my drawing. Becomes hyperemic, which means increased blood flow. Edematous and red. And in more severe cases, can bleed. And small erosions or ulcers occur. These patients can get abscesses. They can form from these ulcerative areas and result in tissue necrosis or cell death. So they can get abscesses, which results in tissue necrosis or cell death. Continued edema and mucosal thickening can lead to a narrowed colon and possible partial bowel obstruction. So the continued edema and mucosal thickening can lead to a narrowed colon and possible partial bowel obstruction. So they can get abscesses, mucosal thickening can lead to partial bowel obstructions. This is a good thing to remember about ulcerative colitis, that the stool typically contains blood and mucus. Different than Crohn's. So ulcerative colitis, typically the stool contains blood and mucus. Patients report an unpleasant and urgent sensation to defecate, and this is called tenesmus. Tenesmus is an unpleasant and urgent sensation to defecate. The lower abdominal area is very colicky, and pain is relieved with defecation. And if you think about where this is located, it's located very low in the rectum area, rectal sigmoid area. So they have this very sudden urge to defecate because they have a lot of colicky pain, and it's relieved with defecation. related to. Even though the cause is unknown, they have found a genetic and immunological or autoimmune dysfunction are suspected to be contributing factors to the cause. They say the cause is unknown, but they've seen a genetic and immunological or autoimmune dysfunction in some of the blood tests that they run. It's genetic tendency and autoimmune dysfunction. So what are we going to see with these patients? Diarrhea, fatigue. The stools, they can have as many as 10 to 20 per day. Imagine. 10 to 20 per day. Often liquid. And as I said, most of the time contain blood and mucus. 10 per day, often liquid and contain blood and mucus. Well, that explains the fatigue, right? When they're losing blood, lack of sleep because they're getting up really all hours of the night. And of course, with all the stool that they're losing, they're getting dehydrated. So you're going to possibly see a fever, and you're definitely going to see weight loss. Definitely going to affect their quality of life, right? These clients may be afraid to leave the house because of severe diarrhea. Totally understandable. So the complications that can occur with ulcerative colitis are hemorrhage, abscess formation, megacolon or toxic megacolon. The definition for toxic megacolon is paralysis of the colon causes dilation and subsequent colonic ileus. That's kind of what ileus is. It stops working, right? But describe it as a paralysis of the colon. This paralysis causes force dilation and subsequent colonic ileus. What do you think this could possibly lead to? Bowel obstruction. Okay, definitely bowel obstruction. What else? If we have a bowel obstruction, what can it lead to? Perforation.
Can you say that definition?
I can. Okay, toxic megacolon is the paralysis of the colon causes dilation and subsequent colonic ileus. Causes dilation and subsequent colonic ileus and possibly perforation. Of course, you're going to have malabsorption end of what?
The small
The
your
small intestine. Thank you. Very good.
Wow.
Breaking it down. Terminal. You're exactly right. So typically it's in the end of the small intestine. It can be spotty, so you can imagine the problems that occur with that, where it can hit a spot and skip part of the bowel, hit another spot, skip part of the bowel. So sometimes a lot of bowel is involved. Characterized by exacerbations and remissions. And the peak onset is between 15 and 40 years. Now your book had some different ages. It just made me think of this. I think it was mostly on the ulcerative colitis. So I'll just expect you to know what's on the PowerPoint because they differed with ulcerative colitis a little bit. Not a lot. I mean, how textbooks are all a little different sometimes. Again, they say they don't really know the cause, but there seems to be a genetic tendency. We see this in families. Again, there's some immune factors that seem to play a role, and environmental factors. So 10 to 20% of people that have a positive family history. So we see this at 10 to 20% of patients who have Crohn's disease will have a positive family history. Some other risk factors are smoking, Jewish ethnicity. I'm not sure why Jewish ethnicity. Anybody have a thought on that?
Probably food.
Okay, any more than just a thought? I'm not sure exactly.
Probably the food.
Yeah, what is the food they eat? I can't think. Apparently is not good about. Okay. And also living in urban areas.
Chicken. Hey.
So that's where the environmental factors come into play. They found that people living in urban areas are more prone to this. It was once thought that stress and nutrition played a role in the development of Crohn's disease. We used to say, oh, it's because they have a high level of stress. We'll talk about other things that happen with stress. But anyway, in their nutrition. But these factors have really not been proven to be true. So as I said, it was once thought that stress and nutrition play a role in the development of CD or Crohn's disease, but these factors have not been proven. However, inadequate nutrition can worsen the patient's symptoms. Abdominal pain is in the right lower quadrant. Weight loss. And the manifestations of Crohn's disease seem to vary a lot from ulcerative colitis. These patients only have about 5 to 6 liquid semi-formed stools per day. These stools are typically without blood. So that's the difference. Ulcerative colitis, you're going to see blood in the stools. Crohn's, typically not. Typically not blood. Some stools may contain fat or steatorrhea, depending on the location. And that's again the absorption issues. Like I said, abdominal pain is usually right lower quadrant, but it can also be around the umbilical licus, before and after bowel movements. It's usually in the right lower quadrant, but may also be around the umbilicus before and after bowel movements. If the lower colon is diseased, they will have pain in both of the lower abdominal quadrants. If the lower colon is diseased, pain is common in both lower abdominal quadrants. Weight loss. Nutritional problems are the result of increased metabolism from chronic inflammation, anorexia, malabsorption. Nutritional problems are the result of increased metabolism, chronic inflammation, anorexia, malabsorption, or self-imposed dietary restrictions. Why do you think someone would implement self-imposed dietary restrictions? So they don't have to go to that. So they may have malnutrition because they're like, if I eat, I'm going to have to go to the bathroom. Which all these result in fluid and electrolyte imbalances and vital nutrient deficiency. And so most of our nutrients are absorbed through the blood from the bowel. Where do we get our nutrients absorbed from? The small intestine, right? So the small intestine is involved in this typically. So it inhibits the small intestine from absorbing nutrients. So the inflammatory bowel changes decrease the small bowel's ability to absorb nutrients. They don't like to eat because they may have to look after, and then they're not even absorbing what they're eating. So complications with this are very similar to ulcerative colitis, but a little different. Abscess and fistula formation are more common. Fistulas. Everybody know what a fistula is? It's a tract between two or more body areas. We form these fistulas from bowel to bladder, bowel to bowel, or bowel to the skin. Fistulas are abnormal tracts between two or more body areas. Bowel and bladder, or bowel to bowel, or bowel to skin. They can have intestinal obstruction, malnutrition, bowel perforation, and underlying hemorrhage is uncommon. Uncommon. Don't typically see it. So I will monitor lab results, specifically albumin, folic acid, hemoglobin, assess dietary intake, and these are kind of combined for both the medications and you see I combine the two diets. Ulcerative colitis. Say in your book that diet is not a major factor in the inflammatory process, but some patients find, so they find that diet is not a major factor in the inflammatory process, but some patients find that caffeine and alcohol increase diarrhea and cramping. Other foods, like raw vegetables, high fiber foods, can also cause GI symptoms. Lactose-containing foods may be poorly tolerated, should be reduced. Or eliminated. Carbonated vegetables, beverages, carbonated vegetables, carbonated beverages, drinks, pepper, nuts, corn, extents, pepper can be attractive in schools, ulceration, nuts, dried fruits, and smoking are common GI stimulants, so they usually want to stay away from them. However, each patient differs in their food and fluid tolerances.
It's all under colitis.
This is all under colitis. They found with colitis, the diet really is not a major factor in the inflammatory process, but find that decreases caffeine and alcohol may be a good idea because they increase diarrhea and cramping. Raw vegetables and other high fiber foods can cause GI symptoms. Avoid raw vegetables and other high fiber foods. Lactose-containing foods also tend to be poorly tolerated. Carbonated beverages, pepper, nuts, corn, dried fruits, and smoking are usually common GI stimulants. But everybody is accepted. All right, with Crohn's, typically if you're having an exacerbation, acute symptoms of Crohn's disease, they will have the patient have bowel rest with TPN. What is TPN? Total parenteral nutrition. How do they get total parenteral nutrition? IV. Okay. So it's not enteral. Where's enteral go?
In mouth.
I find this is a misconception sometimes with students. Enteral feeds are tube feeds. Okay. So total parenteral nutrition is straight through the IV. So total bowel rest. During less severe exacerbations with Crohn's, you may see Vivanex Plus prescribed. Has anyone ever seen our patient get that? I have not. Oops. Vivanex Plus. What Vivanex Plus does, it helps induce remission. These products are absorbed in the jejunum. These products are absorbed in the jejunum and therefore permit the distal small intestine and colon to rest. products are absorbed in the jejunum and therefore permit the distal small intestine and colon to rest. They may also, we're almost done.
Repeat what you said, please.
Okay. So with Crohn's, we're going to do the bowel rest with the TPN during exacerbation. During less severe exacerbations, we're going to do the Vivanex Plus. And this is prescribed to induce remission. So these products are absorbed in the jejunum, J-E-J-U-N-M, and therefore permit the distal small intestine and colon to rest. So they're absorbed before they get to the distal small intestine and colon. So that lets that part of the colon rest. Good. Some other nutritional supplements that you may see for these patients if they're not in an exacerbation, acute exacerbation, are like Ensure or Susticol. And this is to get more calories. They need more calories. These patients are also advised to avoid GI stimulants like caffeine and alcohol. So we want to hopefully give these patients high calorie, high protein.
What did you say, Susticol?
Susticol, S-U-S-T-A-C-A-L, Susticol. So the Vivanex Plus may be prescribed to induce remission. These products are absorbed in the jejunum and therefore permitted the distal small intestine and colon to rest. They're absorbed before they get there. Nutritional supplements like Ensure and Susticol can be added to provide nutrients and more calories. And we also want to teach these patients to avoid GI stimulants like caffeine and alcohol. Some of the medications you will see ordered are antidiarrheal, such as Imodium. Of course, they're going to rule out any intestinal infection. And that's for symptom management. Corticosteroids. Why would we give corticosteroids?
Inflammation.
Right. Increase that inflammation, especially during exacerbation. Sulfonamides are used frequently to decrease prostaglandin formation. Sulfonamides are used to decrease prostaglandin formation in the bowel, thus reducing inflammation. Sulfonamides are used to decrease prostaglandin formation in the bowel, thus reducing inflammation. You're also going to see antispasmodics given, like Benadryl. And of course, antispasmodics decrease abdominal cramping following eating. You may see Flagyl order, which is an anti-infective. And it is bowel-specific antibiotic. And it also has active anti-inflammatory effects. So Flagyl is a bowel-specific antibiotic that has active anti-inflammatory effects. And a fairly new one is Remicade. And it is an immunoglobulin, G. Have you heard of it? monoclonal antibody. And it suppresses tumor necrosis factor. It suppresses tumor necrosis factor. And tumor necrosis factor causes inflammation. So it actually causes an immunosuppression. And of course, we use precaution. So Remicade is an immunoglobulin G monoclonal antibody that suppresses tumor necrosis factor. The tumor necrosis factor causes inflammation, so this is an immunosuppression medication. It should be used with caution. So what should we caution our patient about?
Stay away from the house.
Safe.
Stay away from sick people. Report signs of beginning infection. Avoid crowds. That kind of thing. The next thing is surgical intervention. So what we're going to do is we're going to monitor for test results such as a sigmoidoscopy or colonoscopy. Patient may have colectomy if they have bowel obstruction or may have an ileostomy. So surgery is performed for complications of ulcerative colitis, such as toxic megacolon, hemorrhage, dysplastic biopsy result, or colon cancer. So with ulcerative colitis, we're going to probably do surgery with toxic megacolon. If there's a bad hemorrhage, if they have dysplastic biopsy results, which indicate colon cancer. So we'll see surgery with ulcerative colitis. Surgery for Crohn's is not as successful as for ulcerative colitis due to the extent of the disease. As I was saying, it's kind of hit and miss through the whole colon, from mouth to anus, as it said. If a patient does have a fistula, they will need surgery to have that resected, the diseased area resected. Of course, other indications of Crohn's would be a perforation, massive hemorrhage, which is unlikely because we don't have bleeding as much as that. But it can happen. Intestinal obstruction or strictures, abscesses, or cancer. So surgery for Crohn's is not as successful as for UC due to the extent of the disease. But a patient with a fistula, perforation, massive hemorrhage, or intestinal obstruction, abscesses, or cancer, that will be surgery. So if a patient has a bowel obstruction, typically they're going to have a colectomy. What is a colectomy? A total colectomy, in other words, taking all of the colon. These people will have, they they will have no colon, so they will have a permanent colostomy. Correct? Actually, ileostomy, sorry. So what they'll do is, and we'll talk more about bowel surgery when we talk about bowel cancer or colon rectal cancer, but they will have their rectum will be sewn shut and they'll just have a continuous or permanent ostomy, ileostomy. So if all the colon is taken out, the patient will end up with an ileostomy, which is an ileum, or may have a colostomy. And it just depends on the amount of bowel they remove and the site. And of course, we watch these patients really carefully around their ostomies and their rectal area. Well, I have a case study, so look this stuff over.